So the talk is up there, and as Jason says, our group's been working up in PNG now for many years. But when it comes to pharmacokinetics and PK/PD studies in vulnerable populations, you could easily substitute the word tropical there for Indigenous Australians, rural, remote settings, and other resource-poor areas. So it doesn't necessarily have to be tropical. You could also extend that to vulnerable populations and patients who are outpatients. So the group started out as the Fremantle Malaria Group, and it was set up by Tim Davis, who was most of us did our PhDs with. And but we really sort of moved from Fremantle to a number of institutions in WA, and we've really expanded from malaria to other infections as well. And our kind of this is the pipeline that we dream of, and this is this is the end game for us, and that we like to see opportunities for dose optimizations and perhaps new therapies, and then we take it through an assay development phase. Then we aim to do clinical pharmacokinetic studies in these groups, these vulnerable populations that we're interested in, then apply the sort of modern PK modelling techniques, and then the end game, of course, is to translate those findings into clinical trials which help define outcomes which are relevant for patients. So our group has been heavily leveraging the dry blood spot technology. So our sort of microsampling kind of platform that we've been working very hard on for the last 3 or 4 years has been the dry blood spots. And as Jason says, it sort of really provided many opportunities for us to now collaborate with a number of other institutions that we previously didn't collaborate that well with. But the key ones that I'd like to just highlight is the PNG Institute for Medical Research, who they're a PNG-based organisation that have been doing fantastic medical research for nearly 50 years, and we have a really strong relationship with them. So there's Papua New Guinea. You can see that the border from the top part of Australia to the mainland of Papua New Guinea is only about 6 kilometres, so it's extremely close to Australia, and it's a very diverse place. And you can see Port Moresby down there on the I don't know if I've got the... Here we go. So Port Moresby is the capital here. And the interesting thing about Port Moresby is the capital, and it's sort of where things are happening in terms of commerce and action and government, but it's completely isolated from the rest of the country. And in fact, our group works in Madang province, which is on the north coast of PNG. And this is in fact where Robert Koch did a lot of his early work when it was part of German New Guinea. So there's, that's Madang province, and so Madang town is just here, and our field site is further up the coast. It's about 20 k's up the coast. But in fact, we also work in Port Moresby as well. So, and there's Madang from the air coming in. It's a really lovely, very pretty town. It's on a peninsula. There's the airport and the golf course. So when we're dealing with these kind of patient, these vulnerable population groups, we're interested in the same triangular relationship that we're all interested in. It's really a triangular relationship between the bug, the drug, and the person, and the disease. And at every level, patient variability can affect each of these corners of this triangle. And in the context of Papua New Guineans, we see a whole lot of variability and things about the people of PNG, which is different to that which we see in intensive care or hospitalised patients in Australia and New Zealand. But for PNG, it's sort of there's an added complexity because there's a whole socio-political context in which we have to work that, again, trying to translate what we do in a first world setting to a sort of a resource limited area with a whole lot of challenges is sort of one of the main challenges that we face. But having said that, we believe that these patients are highly likely to benefit from all the upsides of dose optimization that we believe patients benefit from here. So in each of those, basically some of the unique challenges we face in Papua New Guinea is that, firstly, it's extremely diverse. It's linguistically diverse. There are 800 languages, and it's also very genetically diverse. So all the potential sources of genetic variability are in fact amplified in this particular patient group. And when we do genetic studies, which we've done in the past for severe malaria and so on, what we see is this huge, extremely robust population structure genetically within Papua New Guineans. We also see a really diverse and severe range of pathologies in this country. So just going to highlight here a few things. So this is the cardinal pathophysiology of cerebral malaria, and this is a post-mortem brain biopsy we did during our my PhD, which shows the parasite stuck within the endothelium of the brain. And this is a child who's got cerebral malaria. This child here, you can see the sort of arching posture. That's severe severe signs of bacterial meningitis with neck stiffness. And I've highlighted this one here because that's severe anemia, and that's really important for our particular groups of patients that we're interested in pharmacokinetics, because it actually means that the average hematocrit and hemoglobin in Papua New Guinea is considerably lower. And they also have a high prevalence of hemoglobinopathies, which also mean that the population average hemoglobin is much lower than in our settings. So all of that impacts, of course, on our microsampling techniques, particularly when it comes to dry blood spots. TB is another major challenge for Papua New Guinea. In fact, it's got just about the highest incidence in the world of active TB. In some parts of the world, the big outbreak of MDR TB in the Western Province, they have an annual incidence rate of probably between 1 and 2,000 per 100,000 per year, which puts it higher than many of the settings in urban Africa, South Africa. And we see a very diverse range of TB manifestations, and now unfortunately we're also seeing a large MDR outbreak. And when I was up there 2 weeks ago, they just had their first 2 cases of XDR TB, so basically extensively drug-resistant tuberculosis, resistant to with the MDR phenotype, plus resistant to Oflox, plus another injectable. So that's a real challenge. And so drug resistance patterns are almost unknown in PNG, and in fact there's only really one lab in the country. There's a population of nearly 7 million people, and there's only one laboratory which is doing any decent microbiology, and the quality of their microbiology lab was extremely poor. And finally, this is really the first antibiogram we've managed to get from blood culture isolates, which was in 2015 from work that we were doing with the main laboratory at the Port Moresby General Hospital. And you have to understand that there are almost no broad-spectrum antibiotics available in this context. So really the broader spectrum for gram-negatives is ceftriaxone, but there's no piptaz, there's no meropenem, there's no vancomycin, there's no dapto, there's no ceftaroline, there's nothing. And yet, what do we see? Well, when we look at you can see for MRSA rates as a proportion of Staph aureus bacteremias, half are MRSA. And as I say, they don't have any treatment for it. When you look at gram-negatives, you can also see a high rate of resistance to ceftriaxone. I think that's, where is it? There it is there. So you can see that ceftriaxone rates, there's about 25% exhibit resistance to ceftriaxone. So, and the rates are even higher when you look at neonates. You don't need to remember that, but the highlighting point is that in fact drug resistance is much more common there than we expected. And I think that's one of the things that we find with this group of patients, this population, is that they've never really been exposed to broad spectrum antibiotics, so they can't be accused of misusing them, and yet they're suffering a lot of the downsides of global drug resistance. So it's not a safe place. There's a lot of violence and guns and sort of some weird cultural beliefs. The logistics, so this is going on field trips when we're doing our work in PNG. You can see that you're getting yourself obviously bogged. This is another field trip that we're doing to do genetic studies, and the infrastructure is extremely poor, with really poor roading and so on. And this is sort of a pretty typical hospital. This is where we did where we do our paediatric work, and you can see it's very open. It's got good ventilation, but that's the only thing to say for it. And there's often electricity power outages. So this is the kind of context in which we're working, and so we've been working but within that there are a whole lot of opportunities for us to be working and to try and optimise dosing. And this is a well-established field site that we've been working on in just 20 k's north of Madang, and you can see it's actually, it looks reasonably simple, but it's very well established. It's nice and clean. We've got a team of nurses and drivers and microscopists who work really effectively on our studies. And Brian is going to describe a lot of the work that we've been doing on antimalarials in the next talk. Just to give you a bit of a flavour, so malaria has always been a big issue, and this is a study that Hara and Karunajiwa did at the same field site back in 2006 and 7, and what you can see here is that this is treatment for Plasmodium falciparum. We follow patients over 42 days traditionally, and these are 4 different drugs that he tested. And basically for falciparum, you can see that the drug that was most effective was this one here called AL, which is artemether lumefantrine, which subsequently, as a result of this trial, became first-line therapy for uncomplicated malaria in PNG. The downside is that in PNG we also have Plasmodium vivax, which is another parasite which is circulating. And the downside, of course, is that Plasmodium vivax hides in the liver and can reactivate after an infection. And basically you have these sleeping forms in the liver, and you get recrudescence of disease. And so what you can see, although AL was extremely good for falciparum, the relapse rates after Plasmodium vivax were about 70%. And in fact, what we see also is that after an episode of falciparum, the relapse rate for vivax for the next 42 days is about 30% as well. So we're concerned about relapse with Plasmodium vivax, and there's been a push to start thinking about how we might optimise the dose of primaquine. And primaquine's the only treatment that's available to treat the hidden forms or the hypnozoites that are sitting in the liver. And yet we really don't know what the optimal dose is, and the current recommendation is to have 0.5 milligrams per kilogram given daily over 14 days. And so that in itself is a very difficult regimen to offer young kids in these kind of environments. But not only that, so this is a work that Haran's done in Vanuatu, small numbers, but you can see that if you don't have any primaquine after vivax, your relapse rate is 70%. If you do have primaquine, it comes down, but it's still quite a high relapse rate. So this is the standard dose that we would give in most settings. This is the PNG dose of 0.5 milligrams per kilogram, but you can essentially see that the relapse rate at 2 or 3 months is about 30 or 40%. And the really interesting thing about this is this due to a pharmacokinetic interaction? And as I said earlier, the first-line therapy is artemether lumefantrine, and the lumefantrine component of that is metabolized by 2D6, and so it's a substrate for 2D6. And primaquine requires a prodrug, and it requires activation to reactive metabolites, which we really don't know what those metabolites are, but it's also a 2D6 dependent process. And one of the surrogate markers of that 2D6 dependent process is a rise in methemoglobin. So what we see, one of the side effects that we've always been concerned about with primaquine is rising methemoglobin levels. But the concerns is that if you give primaquine close, because it's a 2D6 dependent process, if you give it close to lumefantrine, does that actually affect its bioactivation? And what you can see here is that if you give AL and primaquine straight after, you don't get very low rise in the methemoglobin concentrations. Whereas if you use another first-line antimalarial, DHA piperacin, and primaquine, what you see is you get the rise in methemoglobin. So one of our sort of big studies, and this is one of our major studies coming up, is to look at the optimal timing of primaquine in relation to first-line drugs. So basically give the standard treatment, AL, and then the timing of primaquine in relation to that. And we're also trying to look to see whether or not we can accelerate the dosing schedule from a 14-day regimen down to a 3.5-day regimen. So we've been working in severe malarial infections and severe bacterial infections in Port Moresby, and we've been working this now for 4 years. It took a long time to get off the ground, and that's one of the other challenges we face, is that ethics can sometimes take 2 years. We've been looking at children who've had severe bacterial meningitis and severe pneumonia, looking at Kiftraaxone PK. We've recruited nearly 170 children into a PK study using the dry blood spots of amoxicillin and gent with children with neonatal sepsis, and meropenem for relapsed neonatal sepsis. And at Port Moresby, we've also been looking at first-line TB drugs. So here's the microsampling challenges. This is the study that we did. This is sort of some pictures where I've got our medical imaging people taken in Perth, and you can see a beautiful spot being made. It gets taken out over the filter paper, and so this is a beautiful spot that now our Maju, who's our analyst, can now take a hole punch from and elute the drug and measure the concentrations. So unfortunately, the world is not like that, and we have a sort of team of nurses up there and dealing with really sick children, and so you might think, well, that's terrible, but that's actually, for us, that's quite a good spot. So this is taken from a neonate, and you can see that those are quite decent spots from our perspective, and that would be okay for Maju to take a 6 mil spot or a number of 3 mil spots from that, and analyse the amoxicillin and the gentamicin from that. But it's not always quite that good. And we're finding that I think the biggest challenge into the future is going to be, for the microsampling, is going to be the quality of the spot collection. And there you can see there's a whole lot of dodgy spots. Draw your attention to this one. This one's probably been put into the freezer without the desiccant, so it's got wet. We also have the multiple dab challenge, where people are sort of dabbing onto the spot rather than letting it pull out by capillary action, and sometimes the spots are just too small to be used. So that's one of the challenges that we face when we do these kind of studies, and it's certainly a bit of a challenge. And so to sort of just get our heads around how to do that, we thought, well, at the beginning, when we first did the validation paper, we validated the dry blood spots versus plasma. And the study on the left basically shows, and that was in 10 healthy adults in Perth, where we knew the quality of the spots was great, and we knew that all the samples got stored beautifully, and we can see that there's a nice clear line between dry blood spots and plasma concentrations. And we thought, okay, well, we better make sure that it kind of works in Papua New Guinean children. And so this is the first data. We just got this data last week. And this is the first group of 10 patients that we also collected plasma samples just to confirm that it kind of did work in a resource poor setting. And yeah, for the most part, it's pretty good. The concentrations are quite a bit higher than we saw with the healthy adults in Perth. We also we've got a few outliers, and we're not sure what the reason for that is. We speculate that these two outliers may be related to the fact that the sample's been taken from the line itself, not long after a dose has been given. So that's one of the broad challenges that we face, and it sort of begs the question, and it's sort of really one of the things perhaps we might discuss, is that in these kind of special patient groups, every time you have a new assay validation, or do we need to actually test it in those populations of interest, or can we rely on a sort of a healthy volunteer group to validate the assay? So take a step just away from PNG for a moment, and we're going to just briefly talk about rheumatic fever. And we see rheumatic fever prophylaxis as one of the major, as another potential opportunity for us, but this time in the context of Indigenous Australian rural and remote areas. And rheumatic fever rates, so rheumatic fever is caused by group A strep, and you end up basically the end, we're trying to avoid the end stage disease, which is rheumatic heart disease. So you have rheumatic fever, it causes multiple episodes you get multiple episodes, and that progressively damages the heart valves, and you end up with end-stage heart disease. And this is data from the 50s, which kind of really showed us the opportunity for giving prophylaxis. And what they did is they somehow managed to follow up patients, I think they were for 560 patient years for patients given parenteral benzathine penicillin. So that's an oily drug which is given by intramuscular injection by using oral penicillin or oral sulfadiazine. And what they did is they followed these patients through to see how many patients had relapses. And you can see very clearly that the rate of, if you got monthly benzathine, that your rate of relapse over many years was reduced. The problem with these early studies is they weren't accurately able to ascertain whether or not a patient truly had worsening heart disease because you couldn't make a diagnosis of rheumatic fever. There was no echocardiography. So this was interesting, but the reality is that in these patient groups, even if you have benzathine penicillin, you can develop about 25% of relapses occur in patients who are apparently getting compliant or adherent to their monthly benzathine penicillin. So there are a number of concerns about the pharmacology of benzathine penicillin in this group. And so the sort of conventional wisdom is that if the MIC is 0.02 milligrams per litre, and that you are protected for the time that you have a concentration above 0.02. And that's the conventional wisdom for benzathine prophylaxis. And so this is a population PK model in healthy military recruits who got, I think they were getting their benzathine for syphilis or gonorrhea at the time. But basically you can see that this line here is 0.02, and that more or less 50% of patients, this is the median line, are actually have levels below 0.02 at about 2 weeks. And so that suggests that half the time, more or less half the time, if they're getting monthly prophylactic injections, they essentially have low concentrations. And that is potentially one of the drivers of rheumatic fever relapses in this population. So we sort of thought that there's an opportunity to look at benzathine pharmacokinetics in Indigenous children who are receiving benzathine prophylaxis, and we decided to start in Perth. And there's a cohort of children who are receiving prophylaxis, and as you can kind of imagine, these are community-dwelling children, and they obviously don't like venesection. They tend not to like the injections. They hate the injections. And they're quite a hard group to actually do pharmacokinetic work in. And so there's about a cohort of just under 30 patients in the Perth metro area who are getting monthly benzathine that we know about. And so we basically recruited actually nearly 80% of them who have agreed to participate in the study, and we're really relying on the dried blood spots for that. And so what we do is for each, we follow the children for 6 months to see whether or not they develop signs or symptoms or throat swabs consistent with acquisition of new group A strep infection, or a relapse of the rheumatic fever, or some indicator, some pharmacodynamic factor that might indicate that they've failed therapy. And then for each of the children, we're doing an intensive month and then a number of other random samples during that time to basically build a population model for benzathine in this population group. And so that was the study design, and so we sort of thought, well, okay, let's try we were keen on using the dried blood spots for this, but it did present a few sort of issues, and it kind of highlights some of the challenges that we face in kind of designing studies and designing assays, because the assays have to be fit for purpose. And in this setting, so in some of the studies that in sick adults, the very low concentrations don't actually matter that much, because all of the money is in the high concentrations, and usually the trough levels are still relatively easy to detect. Whereas because we had to demonstrate levels above 0.02, in fact we need to have a level of quantification quite a little bit below that as well. And so that was actually one of the key components of this study design, is making sure that the limit of quantification was low. And the other thing that we needed to do is Perth's a hot place, and we're out in the community and the nurses are out there doing blood spots. What do we do if it's 45 degrees in the car and we're trying to dry the samples? And so we're very keen on thermal stability studies in this context, and Madhu and Bryony have been working really hard on trying to work out how to optimize the sampling techniques and the drying process for those samples that we take out in the community. And so you can see that this was sort of a study that we did, just comparing. This is just a validation study comparing dry blood spots with plasma. You can see that broadly the concentrations accord. There's a few patients up here. There's a bit of a lesson in doing pharmacology, is that we didn't realise at the time. So these patients here are ones who are receiving continuous infusions of penicillin, and they had very high concentrations in their plasma. And because I didn't want to cause them too much distress, we ended up taking the sample from the PICC line, and I didn't realise that it's likely that the penicillin actually absorbs onto the internal lumen of the PICC line and falsely elevates the measured plasma concentrations. So that's a mistake we won't be making. But fundamentally, the assay works really well, and we ended up with a limit of quantification just about 1 order of magnitude lower than the 0.02, which is kind of what we're aiming for. And you can see that if you can get, so these are stability studies that we do for all of these validation studies, and the black is minus 80, and this is refrigerated temperature. So this is kind of what we do when we're trying to when we're out in the field. We try and cool them down reasonably quickly. So an esky or a car fridge, usually with desiccant to facilitate the drying process at a lower temperature. I was going to talk about TB, but I think that I might actually just leave it there, Jason. We are just ready to. There's a lot of variability in tuberculosis, and we've also we just started another PK study up in PNG, looking at patients receiving first-line drugs for TB. And like I say, I went up there about 3 weeks ago, and I recruited 3 patients in the morning. So there's just there's so much TB up there, and there's so many opportunities for this kind of work. This is just some early data we did on rifampicin and desacetyl rifampicin, cipro and fusidic acid. So like I say, I think I'll leave it there, and thank you very much.